So recently the FDA approved, based on the PSMAfore data, Lutetium-177 for treatment of mCRPC patients pre-chemo. Has that had a significant impact in your practice?
It has, and I think also to Ken's point, the side effect profile of docetaxel, you can't overlook it. You really can't. And so in that situation, upfront offering of lutetium, I think is a great option for these patients to, again, give them an option that maybe doesn't have as much of a adverse effect profile, as chemotherapy would up front.
Any warning signs or concerns with the PSMAfore data that came out?
My only thing is kind of circling back to what we talked about early on about good imaging. I think as these patients transition from, if they've gone from mCSPC onto mCRPC, we don't want to miss those windows of potentially giving them CYP-T or radium-223 early, and potentially both sequentially. I think the risk is they get lost to follow-up, or maybe they're not seeing, advanced, uro-onc guys like we are, and that window is missed, so they come back, instead of their PSAs now up to 2 or 3, where we could say, hey, how about CYP-T or how about radium-223? They are now symptomatic. That PSA is 50, 100. They've missed that window, and now you've got to kind of catch up and go right to lutetium. So again, I think it goes back to why is screening on a regular basis and monitoring these patients early on for a long period of time and not letting them kind of disappear when they're doing well critical.
Yeah, I think you brought up earlier too that radium-223 Alsimca trial, great data. It's been around a long time. We've been using radium for a while and seeing good results, but it's kind of been forgotten. But it was recently re-energized with the PEACE-3 data that showed in combination radium with enzalutamide is effective. Do you think that will be impactful in your practice? Is there certain patients where you would consider enzalutamide plus radium based on the PEACE-3?
Yeah.
Or any patients you wouldn't consider that in, I guess, where you would not want to use?
I have to think about that.
Probably a history of CVS, stroke, and stuff
of course,
like that.
Contraindication.
But I think way back in the day, when there wasn't this epidemic of mCSPC patients, when we were monitoring some of these CRPC patients as they developed, that was really a lot of our plan, is we'd give guys CYP-T, maybe go right to enza and radium-223 kind of in a relatively short period of time. And again, I think there's some synergy to getting all that in on that next phase, and those people just seem to do well for a long time. Again, it's just critical not to forget about radium-223.
No, that's a great point. So we have a few minutes left. I think I want to just go down the road. Key takeaways with all this innovation. What are some of the ideas and how to integrate all these new great therapies into practice? Ken, I'll start with you.
You're the master of guideline-based medicine, right? You've helped control or construct ours. We've all helped with that. I think that's really the critical piece, right? We're excited that there's all this new stuff. There's hope. These guys are living a long time. It's a disease of chronicity. Guideline-based medicine is, I think, really key, so we're not skipping steps. I think it's also really, it's important for us to stay on that cutting edge, which we all do. And again, I think the biggest takeaway is the hope for our patients, to sit with these patients, like you said, at the beginning and say, look, you're going to live a long time. We're going to be aggressive. You're going to get to your kids' graduations, birthdays, celebrations, all those things. And we've all had these patients who really are almost super survivors, and that's really the hope. So I think guideline-based medicine is key. Don't miss anything, and really continue to offer our patients that hope.
No, that's a great summary. What about you, Rene? What are some key takeaways for managing advanced prostate cancer patients?
Well, I think, again, staying on top of the game, ahead of the game, I would say, testing, genetic testing, repeating. And like Ken said, we have to guidelines. We have to remind ourselves. I had forgotten some of these things, I think we have to keep reminding ourselves and not get confused of what's coming up, but we can forget about what has been too unproven already. But keep testing, genetic testing, for somatic mutations. I think that's important.
Dr. Palka?
Yeah, I would say for me, being a younger physician, it's a very exciting time to be coming into this new world of treatments and testing. And I think as the data continues to roll out and different trials are organized, and we not only have newer trials but also the durability of the older trials to really prove to these patients, like Ken said, give them hope that, you know, I can tell them that they're going to be able to make it to their kids' birthday parties or weddings and things like that. And I think it's a really exciting time to be coming into this sort of this new world of prostate cancer.
Yeah, I agree. It's an exciting time to have all these options for our patients, because when I left residency and fellowship, we only had docetaxel.
Right.
And, you know,
Biclutamide,
I'm getting
you know?
biclutamide.
That's all you
which-
had.
At one point, Ken and I were putting stop signs in, stop using
Yes.
biclutamide
Yeah.
to the office.
Yeah, right.
1989 technology.
Yeah.
We've moved past that. I think the key takeaway here is that for all of our patients, that we have all this great technology, and I think the greatest mistake is not identifying the therapeutic windows where the data supports the utilization of these therapies. Because when you look at good advanced prostate cancer care, you want to make sure that each of these patients were offered these therapies and their appropriate therapeutic windows, and throw on, you know, the cherry on top is get them into a clinical trial. So I can't think of nothing better than discussing advanced prostate cancer with, you know, three of my colleagues. Really a great discussion, and really appreciate the time.